topic is going to be tubulointerstitial diseases, something that I always have trouble spelling. And Shree Sharma is going to lead us through the pathology. We have Tiffany Kaza, who will be in the chat, if we can get this set up for her to answer questions. And the moderators will be myself, I'm Matt Sparks, and Samira Farouk. Do you want to say a few words?
Yeah, good morning, everyone. My name is Samira. I'm a transplant nephrologist at Mount Sinai in New York City. I'm really excited to be here on this Saturday morning and learn a little bit about tubulointerstitial diseases from Dr. Sharma. So Dr. Sharma, whenever you're ready.
And just a couple of housekeeping things. You can chat with the hosts and ask questions, and we will either have that answered by Tiffany Kaza in the chat, or Shree will answer them live if we have questions that you have. So today's topic again is tubulointerstitial diseases, and you'll have a firsthand view live microscope from Shree. So go ahead, Shree, when you're ready.
And I think you all can see my microscope live. So tubulointerstitial diseases, I know it's a big name. So basically, whenever you see a patient, either the patient can present with a lot of proteinuria or acute kidney injury where the creatinine goes up. Most of the tubulointerstitial diseases are not going to have a lot of proteinuria. A variable amount of proteinuria, but generally subnephrotic if it is a pure tubulointerstitial diseases. And AKI is one of the most common manifestations which you see. Most of your consults in day-to-day life are AKI. So whenever you go and see your patients of AKI, one of the most common questions which you have when you see the patient, is it acute tubular injury or is it acute interstitial nephritis? You know, and you do a biopsy because of that. And one of the main questions when you call me and ask, is it acute tubular injury or acute interstitial nephritis? So let me start there. So this is a kidney biopsy. You ended up doing a biopsy on a patient who was admitted with a baseline, with a creatinine of 4, with a baseline creatinine of 1. And you gave me this biopsy, and this is what the biopsy shows. In most of our previous sessions, we were focusing on the gland. In this session, we are going to focus on the tubulointerstitial compartment. I will divide that. Tubular, that means tubules. Interstitial, that means the area in between the tubules. So we are just going to confine ourselves in those two areas today. Tubulointerstitial compartment. So when I look at this biopsy, I see a bunch of tubules and I see the area in between the tubules. I don't see a lot of inflammatory cells here. The interstitium is pretty clean, but the tubules, which are the spring lining cells, they are little dilated. They are little dilated, and some of the cells are showing vacuolation. When I go on high power and start moving around the tubules, I can see the nucleus of the tubules. It is little enlarged. The chromatin is little opened up. What do I mean by that? If you see this chromatin, it is little dark. In contrast, if I see this nucleus, the chromatin is little opened up, and there are few cells which are showing you nucleoli. All that means is the cell is very active. It got damaged by something, and now the cell is active. This is acute tubular injury. Are all the cases going to look like that? No. All the cases are going to have variable morphology. This is one of the forms, which is a very mild form of tubular injury. So when you move around across the biopsy, that is what you are going to see. You're going to see tubular dilatation. You are going to see prominent nucleoli within the nucleus, and you are going to see variable amount of cytoplasmic vacuolization. So the next question is, who is the driver of tubular injury? Because acute tubular injury is just a morphological pattern. So you would like to find out who is driving that tubular injury. So you look around, most of the lumens in this case are empty. So it is not something which is getting deposited in the kidney. The lumens are vacant. Many times you might end up seeing something within the tubules, which are known as casts. They might be driving the tubular injury. We are going to focus on the intratubular cast selectively in January in the next Arkana live session, but we are not going to discuss that today. Today, we are going to focus simply on ATI, and most of our cases, we don't know the driver. That is the practical life. In most of the cases, you're not going to figure out the driver on the basis of pathology alone.
So
One
can you
other
comment
morpho-
about Shree, can you comment on the difference between ATI and ATN?
Yeah. So ATN is basically also a tubular injury, like injury to the tubules. I'm using the word ATI instead of ATN. ATN is an extreme form of injury where the cells are actually undergoing necrosis. Over here, the cells are damaged, but they are not showing you necrosis. That's why I'm using the word ATI, not ATN. ATN to me is an extreme form of tubular injury. Okay. The other morphological point does that answer your question, Samir?
Yes.
Okay. So other morphological feature which I want to point out, ATI, acute thing, right? You are seeing interstitial edema over here. So I want you to appreciate the bluishness of the edema. This is an H&E stain, and you can see that edema, the interstitium is bluish in appearance. So what happens in acute tubular injury, the interstitial edema will be present. And why that is important? Because many times when we are starting our pathology training in nephrology, we focus a lot on the trichrome stain. So we assume everything which is blue is fibrosis. And that is not right, because this, I said, is interstitial edema, which is not fibrosis. But when you go and look at the trichrome stain, it looks blue. So you might end up interpreting that as fibrosis, while in reality it is not fibrosis. So in this case, basically, there is no interstitial fibrosis. It is all acute. There is interstitial edema. So that is important for us to appreciate that. So in this case, there is a lot of interstitial edema, but it's pure acute tubular injury. But the morphology of
Can you
tubular
go over
injury,
that one more time? I think I was trying to understand that, but
okay.
Why is
Okay.
that blue different?
Why is that blue different?
Because I think you're right. We see the trichrome, we see the blue, and we
Yeah.
think it's fibrosis. So why is that blue different again?
Yeah. So if you are looking at the trichrome stain alone, you won't be able to figure out this is interstitial edema. You
Okay.
will think this is interstitial fibrosis, but you go back and look at your other stains. So I will come back and look at the H&E stain, and I will see the area which was looking blue on the trichrome is more bluish on the H&E stain. If it was fibrosis, I will show you some other cases of fibrosis, it will be more pink.
It'll be more pink.
Look,
okay.
Yeah, this edematous look is very specific for acute condition, not chronic. The other hint which you can take is from the PAS stain. So if I go back and look at the same area which I showed you on a PAS, this was the area I was showing you. See the tubules around it, they are not showing you thickened basement membranes. The basement membranes are not very thick. If it was a tubular atrophy and interstitial fibrosis, you will start seeing thickening of the TBMs also. So that is again an indicator for you that you're not dealing with a chronic condition. So in your case, in this particular case, there's not a lot of IFTA, but interstitial fibrosis or tubular atrophy.
So
the TBM also looks a little bit wrinkled when you have tubular atrophy, correct?
Yes, you are absolutely right. And we'll show some cases.
The take-home message for us is that when you look at a trichrome stain and you see a lot of what you think is fibrosis, don't stop there. Look at the other stains to make sure what you're seeing is either acute or chronic. And one of the ways to do that is the H&E. If it is pink in color, it's likely chronic. If it's kind of this bluish edematous color, then it's probably acute.
Yes, I absolutely agree with that comment.
Got it.
Yeah. And many times it is not possible for, like in this case, this is again another example of tubular injury. Can you see the separation out here amongst the tubules? But it looks a little chronic just on the biopsy. Why do I say that? Because it is not as blue as we had seen in the last time. And you can see some inflammatory cells over here. So normally but am I going to be 100% sure on H&E stain? No. I have to look at other stains like PAS, trichrome, and silver to make sure this is the right finding which I'm interpreting on the H&E. But in this case, again, same acute tubular injury, a little different morphology. You can see the injury to the tubules, okay? And over here, the tubules are not much separated from each other. There's only a little bit of separation.
Those tubules there, is that term vacuolization, those kind of bubbles that's in there?
Yeah, I agree.
Is that something indicative of just the injury or the necrosis?
It
Or
is
is it
just
kind of in the
indicative of
middle?
the injury. The
Just
cells are injured, and the extent of vacuolization will be highly variable from the case to case. So I'll show you a case which had an extreme form of vacuolization. Like in this one. Can you appreciate the vacuolization? It is so prominent in this one. So many times when you see prominent vacuolization in transplant setting, we think about tacrolimus, and classically we say there are isometric tubular vacuoles. By that we mean the small vacuoles which you are seeing are of almost of similar size. That's why we call that as isometric. And in native cases, when you start seeing vacuolization, you think about like osmotic causes of tubular injury, But vacuolization is not very specific. You will see it is good when you get right, when you can correlate that with the clinical history. But most of the time, it is non-specific. It is not very specific of a particular etiology. But it is just a non-specific finding of tubular injury. And in this power, like if I show you, you will always say, I'm seeing acute tubular injury. See, the nucleolus is so beautiful. This chromatin is totally opened up. And in this area itself, you're seeing a lot of tubules which have that morphology. And again,
What are some other causes of isometric vacuolization other than calcineurin inhibitor toxicity?
osmotic agents are, but they are not isometric. So classically, when you describe isometric, the buzzword is CNI toxicity in a transplant. Others like
I still don't quite understand
like
the
like
isometric.
mannitol, in native conditions, they have been given as a cause, but they are not like isometric. They are just plain causes of cytoplasmic vacuolization. Yeah.
The isometric part, I don't necessarily see that. To me, it looked like they were all over the place.
I agree.
Is
It is
there?
very difficult, yeah, in practical life. So by isometric, they mean the small vacuoles which are seen, they are of a similar size. But again, as you said, it is very difficult to appreciate, and it is not typical, it can be seen in multiple other conditions.
So there's a question in the chat about how do you grade mild, moderate to severe ATI, and what are the criteria that you use if you're going to put that into a report?
Yeah, ATI are not graded as mild, moderate, and severe. There is no formal guideline on grading them as mild, moderate, and severe. But if you call and talk to me, I will let you. So initial cases which I showed you, they are mild, like mild to moderate. The next one with a lot of vacuolization. And this one will be a severe form of tubular injury. Can you see the lining epithelium is almost completely gone over here? And see the nuclei, they're so prominent and reactive. And most of them, they are totally sloughed up. You cannot even see the lining epithelium over here. So to me, this is an extreme form. But there is no formal grading system as mild, moderate, and severe. But when I talk to you on phone, I will let you know, hey, this is a very bad ATI. Patient is not going to recover most likely. He will stay on dialysis for a long time. But again, what I say is that going to be 100% right? No. So there is no grading system for ATI.
And that staying there, I just want to this is, so we can go back to it. Can you put it back up? Yeah. So just for everyone, I'm trying to make this very simple. So I'm looking at this and I see like it's making a lot of things red, which some of them look like red blood cells. So that makes me think that this is an H&E stain.
You are absolutely right, Matt. So
and if they didn't, and you would see the basement membrane more, then it would be a PAS.
You're absolutely right.
So I just want to like make sure people recognize these things so that, the basics, we want to make sure these are people that maybe have never done PATH before ever.
Yes, I really appreciate that. And I love when you make things simple, Matt. This is very important because I want everyone in the audience group to understand that basics. So thanks a lot for bringing that up.
The PAS doesn't turn the red cells color. You can kind of see them. They're kind of ghosts. But H&E, they really you can see them. So that's my pearl of the day.
Perfect. And as you see, like I'm focusing more on H&E as I'm studying tubular interstitial diseases. While I was showing glomerular diseases in the earlier sessions, I used to love PAS, right? Because glom is mostly basement membrane and the matrix. While in the tubular interstitial compartment, those stains are important, like PAS and everything. But you want to understand the general morphology, as Matt predicted, like, okay, the red one is H&E. So I want to see what's going on in the tubule. I want to see what's going on in the interstitium. I want to see what kind of cells are there. So in this one, you can see some cells, but I'm still not using the word interstitial nephritis here. I will use that later on. Still, it is acute tubular injury, and I'll go over the differences later on. And as I pointed out, Let me show you a PAS, and you will be able to see why that stain was H&E, and this is PAS. And this is PAS.
It's quite beautiful.
It's quite beautiful, and you cannot see the red blood cells, which you see. These are the ghost cells, as you said. They appear as ghosts, right?
Everyone's going to be a master differentiator between H&E and PAS.
Yes, I want that. And silver is pretty easy because it is black in color, and trichrome again is pretty easy because it is blue in color. So one important concept I want to tell you now. I said a lot about acute tubular injury, okay? Your patients are going to have, sometimes they stay on dialysis for a while, and I said acute tubular injury, so theoretically they should recover, right? They should come off of dialysis and they should recover the function completely. But what happens if acute tubular injury goes on for a while? I explained to you the concept of interstitial edema that appeared blue on H&E, and this one is more pink. Can you see that difference? Still, I see something is going on within the tubules. There is tubular injury, but I see that separation in between the tubules, and this is no longer blue. It is pink. Isn't it, Matt? Can you appreciate that?
I can. I know this is like beginner here, but yeah. First off, you can almost be fooled to think this is PAS, but if you look closely, you see some red cells. I see them. They're hanging out.
Yeah, they're hanging out.
You don't see basement membranes very well. I see some vacuolization of some tubules, and definitely some pinkish. I'd want to. I'm really want to see the same slice with trichrome.
Okay.
I think the other thing that helps you know it's not PAS is that you don't see that clear outline. Like it feels like under the PAS, the tubules have been outlined with a thin marker.
Oh, wow.
Same feed on a trichrome. Can you appreciate the fibrosis, which is so
This is not good. This is not good, Shree.
Yes, that is exactly.
We got pink on the H&E. We got really intense blue. It might make a good painting, but definitely not.
So when I tell you, man, about this patient, if I say acute tubular injury, you will be misguided, right? So I have to come up with a terminology so that you know the prognosis is guarded, and this tubular injury is a long-standing one. So in those cases, we use the term protracted or a long-standing or a chronic tubular injury. So we use the term protracted tubular injury. So you get the sense, hey, this is a tubular injury which is long-standing, and there is a disproportionate amount of interstitial fibrosis in this one, and your patient might not do well depending upon the extent of fibrosis the patient is having. Like in this one, the other indicator for you, I will keep this field on. This is a beautiful field. And you know, in this field, this is a tubular interstitial process, because whenever you are seeing the globs, they are all intact. If it was a non-specific chronic disease, or if it was a glomerular disease, you should have seen scarring of the globs. You should have seen global sclerosis. In this field, you don't see that. You see just fibrosis over here. So this is a tubular interstitial disease. This is a long-standing tubular injury. So we will use the term protracted tubular injury on this one.
There's a question about whether you would see tubular basement membrane thickening in a protracted tubular injury.
Yes, we will. Yeah.
So now we want to see the PAS. Is that what? That's what we're. Oh, there we go.
You read my
Ask
mind.
and you shall receive.
Can you appreciate the TBM thickness right here?
Yeah. And again, that's PAS. So you see those basement membranes. You don't see red cells. Yeah. It does look a lot. It's not as thick as I thought, but definitely it's thicker in a lot of places.
Right? It is on its way. Not completely gone yet, but it will go soon. So this is completely gone, right? So this area is completely gone. Can you appreciate that? The fibrosis is totally formed, and you can see a lot of thickening of the basement membranes, but still a lot of inflammation, okay? Still not a lot of inflammation. Can you see that? It is pretty black.
Yeah, I can see that.
Yeah. And I want you to remember this morphology.
We're going to be, everyone on this call is going to be tubulointerstitial experts by the end of this.
I agree with you completely. So believe it or not, so we are done with ATI. It's a variable morphology with ATI. And this chronic part is sometimes difficult to understand. The chronic ATI or protracted tubular injury, that is again a very important concept. In most of the cases which we saw earlier, there was no inflammation. So everything was ATI, and for clinically for you is ATM. So basically for you, it means no steroids, right? So now in the slow power, when I show you this slide, you know that something else is going on in this one because you can see a lot of blue in the
Get
low
it in
power.
focus just a little bit better.
Let me go on high bar to focus.
Okay.
there.
Oh
Good
my,
enough?
we have got some soldiers that have
Yes.
entered.
So all other cases were totally blank. You didn't see anything. And now you have started seeing stuff in the background. So immediately you will know this is interstitial nephritis. Okay. So just presence of mere inflammation.
Is this like a really crazy high amount or is this normal?
This is a crazy high amount. This
Okay,
is
good.
definitely not normal.
Okay, good.
So the other slides which I showed you are kind of a background image. They were not having any inflammation. They were having disease, but no inflammation. In this case, it is a tubular interstitial process, and you're seeing a lot of inflammation, and that is not normal.
Well, go back to that. So right here, I want to stop right here and in the chat or ask some of just chat with us. What do y'all think this is? What kind of stain that is?
Yeah.
Is this PAS or is it H&E?
It is H&E.
There
and
you
I will
go.
follow your same criteria, Matt.
Yep,
Those
Mike.
red cells are prominent. So that criteria will hold up most of the time. So,
Most of the time.
yes, because
And basement membranes you can't really see. So
you
it's
can't
perfect.
really see. And you can see the cells beautifully. You can see those nuclei beautifully. So you know you are looking at an H&E. And going back to your medical school days, Matt, do you remember how many types of white blood cells are there?
Oh gosh. Well, it seems like the number of white cells are increasing dramatically. So let's go with B cells, T cells, and macrophages, and maybe some dendritic cells are in there.
So if I go back to our medical school days, I didn't know anything about B cells, T cells. I just knew there are lymphocytes, there are neutrophils, there are monocytes, macrophages, there are eosinophils. Plasma cells generally don't show up in the peripheral blood. You talk about plasma cells when you talk about organ system. So those are our basic white blood cells. So on morphology, you cannot distinguish between B cells or T cells. So let's not worry about it. So we will call them as lymphocytes or lymphoid cells. We will call them plasma cells, neutrophils, eosinophils, and some macrophages. So entire spectrum of interstitial nephritis is a play of all these inflammatory cells. So when you see cases of interstitial nephritis, you will see all kind of inflammatory cells or white blood cells, which I just mentioned, okay?
We got to get those out of there.
Yeah, I know. So that is your job. My job is just to say what is there, and you are going to kick them out, okay?
Kick them out.
So how do I identify them? And identifying them is important as a pathologist because I will say most of the time, I cannot tell you the etiology, but sometimes I can tell you the etiology depending on the type of inflammatory cell and the pattern. So we'll see some of the specific diseases, but over here, we can just identify the cells. So cells which are having single nucleus, like this one is a plasma cells because it has a cytoplasm. This cell, again, is a single nuclei cell, does not have a lot of cytoplasm. So these are lymphoid cells. And you can see some cells which are having 2 or 3 lobed nuclei. They are neutrophils. And you can see occasional cells over here, up in the field. I will bring them down now. You can see the cytoplasm is little red. This one is little red cytoplasm. So they are eosinophils. So eosinophils are easy to identify because
It's like bone marrow in here.
Yeah.
Tell me, is it anything you can glean for what type of AIN it is or what the etiology is by the types of cells, or is it all just sort of a conglomeration of cells?
It is conglomeration, but I will give you some hints as I go through the cases so that I, as a pathologist, can predict the etiology. So that will be the beauty, and I'll impress you with that, okay? So I can just tell by looking at a case what's going on. But in most of the cases, that is not true. It is just acute interstitial nephritis, and you will see variable mixture of the cells. And the way it differs from the bone marrow, Matt, is that you don't see progenitor cells, you don't see megakaryocytes, erythroids. So sometimes you can see extramedullary hematopoiesis within the kidney, but this is not the case. You are just seeing variable types of cells. So I said, I'm seeing variable type of cells. So just the presence of inflammatory cells is not equal to acute interstitial nephritis. You call something as acute interstitial nephritis when you start seeing damage of the tubules. What do I mean by that? Okay, so I said there are a lot of soldiers as WBC in the background. they have to come and cross the TBM barrier and cause tubulitis to cause something as interstitial nephritis. And that is the key for us. Just mere presence of inflammatory cells is not good enough for us. We want them to damage the kidney to cause something as interstitial nephritis. And this criteria becomes very important when you are dealing with non-specific chronicity, because inflammation is part and parcel of chronic kidney disease. Whenever there is a chronic kidney disease, you will see inflammation. But you call something as nephritis, interstitial nephritis. When you see the inflammatory cells, they go ahead and damage the tubules. Can you see that? So this concept is simple. And you can extrapolate this concept anywhere you want to. If I show you a transplant case, you will call this as a rejection. And depending on the number of lymphocytes which are crossing the barrier, you will classify 1A, 1B. So in the same concept, you ended up learning AIN, and you also ended up learning about transplant rejection. Okay, am I making sense? So
Yeah, making a lot of sense.
okay, so you are looking at basically acute interstitial nephritis. And why am I calling this as acute is because I'm not seeing a lot of scarring in the background. Still, the disease is mostly acute. This is mostly interstitial inflammation and tubulitis. And you can see there is not a lot of TBM thickening in the background. That's why it is okay for me to use the word acute interstitial nephritis. It is an acute condition, interstitial, because I'm seeing inflammation within the interstitium, nephritis, because I'm seeing tubulitis in the intact tubules. So all of those words are.
The stain is what? What is the stain? Is this?
What do you think?
Sorry, go ahead, Matt.
Oh, I'm trying to figure it out. Like, is it?
But I will follow your criteria.
Is this trichrome?
No, this is PAS. Because you cannot see the cells, like the red blood cells. Yeah,
but wouldn't you? But you're talking about looking at the interstitium and fibrosis. So I thought you'd be looking at trichrome. That's why I didn't understand.
I can see that with PAS also, because I gave you the hint of TBM thickening concept. So I'm looking at the PAS and telling you that. Because sometimes, yeah, go ahead.
No, sorry, I was just going to say, you mentioned, cells breaking the barrier. So there's a question when you use that term damaging the barrier, do you mean that you would see a break in the tubular basement membrane?
We don't see that morphologically. Yeah, but the tubules are getting damaged by tubulitis. And can you see the trichrome? This is trichrome and the blue. There is not a lot of blue, but still there is expansion of the mesangium because the inflammatory cells have come, damage is continuing. There is interstitial edema, right? But this interstitial edema is not equal to ISTA or tubular atrophy or interstitial fibrosis. Okay. And depending on the type of AIN, okay, you might end up seeing different kinds of cells. By that I mean a lot of lymphoid cells, a lot of eosinophils, but most of the time they don't mean anything. Like you cannot kind of specifically say this is it. Like this is a low power, and you can see a lot of cells which are having single nuclei. So these are mostly lymphoid cells and some plasma cells in the background and some neutrophils. Okay. So in the last case, which I showed you, you had a very good admixture of different kind of cells. In this one, you kind of see prominence of mononuclear cells, lymphoid cells and plasma cells. And I know you love eosinophils because whenever we talk about interstitial nephritis, we talk about eosinophils. So I'll show you a case which has got a ton of eosinophils and you don't have to hunt for it, okay? Can you see eosinophils in low power itself? Ton of eosinophils. So in the books and according to like concepts, most likely this patient is having drug-induced hypersensitivity or allergic interstitial nephritis, So you can see a lot, but that is not.
Put your arrow over one of the eosinophils. They're the ones with the kind of, they've got a nucleus and then some pink next to it.
Yeah, this nucleus, this is a classical one. See, binucleate nucleus.
And those things are just putting off bunches of things that are causing allergic reaction in the kidney.
Yeah.
So you can see that. And there's no extra stain you have to do. It's just that.
H&E, just H&E.
Got it.
Well, the E is for eosin, right?
Yeah, E is for eosin. And according to
that's a good thought.
Yeah. And there's also a lot of red blood cells are within this slide as well.
There are a lot of red blood cells in the background. Yeah, you can see that.
It's almost hard for me to I guess the eosinophils are a little bit of a lighter color than the red cells.
And they have that purple nucleus.
Yeah.
and a notch less than the red cell. Yeah, if it is a 3+, this will be like a 2.5 to 2.
Okay, so just to recap that. So first off, you look at the interstitium, you see all the immune cells that have infiltrated in. You kind of get a sense for how chronic or acute it is based on the fibrosis that you see. And then you get a sense for what the cell type is. And so far, we've looked at eosinophils, and that's when you call the nephrologist and say, you need to look at the drug history ASAP.
Yeah.
So
For
Shree,
me-
I just circled a cell using the annotation. That's an eosinophil, right?
No, that is not an eosinophil. That might be some debris, maybe a squamous cell, which came from.
Oh, I found some debris. All right, that's nice.
Yeah. Bring your arrow right here.
It looks
Can you
like
see
it
my
has
arrow?
eyes. There, okay.
Yeah, I know.
Okay. All right, so that's good. This is really a lot of learning here, and we hope we're not going to put all the pathologists out of business.
I'm not going over complexities yet.
Okay. We're just getting some confidence here. Let us live this confidence.
Yeah.
So Shree, there's a question about, is there a way that you can identify monocytes, and what do you think about when you see monocytes?
So monocytes are the cells which are going to have single nucleus, and on the biopsy, they are going to look like lymphoid. So no, you cannot identify monocytes separately within the interstitium. You can make a guess. So if I give you a peripheral blood picture, the character of the cytoplasm is very different, but you are looking at single cells in the peripheral blood. That's why you can characterize them. But when you look at the tissue without doing specific markers for those kinds of cells, on morphology, you cannot distinguish them. But monocyte and macrophages, if you end up seeing a lot, you are going to go more towards a chronic disease. So it's not that they don't help you out. Interstitial inflammation, as I said, in acute condition, most of the time it is admixture. It's not helping you out. But if I see some kind of cells more prominently, I can give you an etiology. I'll show you some examples. I have some examples. If I see a lot of neutrophils, I'm going to think about infection. If I see a lot of EOs, I'm thinking about allergic. If I see a lot of monocytes, macrophages, I'm thinking in a chronic direction. If I see a lot of plasma cells, I'm thinking more in terms of autoimmune etiology. So they are indicative of etiology, but they have to be out of proportion for me to go towards etiology. So the cases which I showed you had kind of a right admixture. They were not jumping out. And I'll show you cases where they actually jump out, and you can actually predict a diagnosis, okay? So let me show you a case where they are actually jumping out, and you can make a diagnosis, okay?
So Shree, one last question about that last slide about the red blood cells. There's a question of, was that, would you call that, quote, hemorrhage? And does that play a role in how you classify the pattern of injury?
Yeah, that's a good question. So just mere presence of few red blood cells in the interstitium is not equal to interstitial hemorrhage, because sometimes you will see blood just because of the procedure itself. And a good way for you to identify that, when you look at the code of the biopsy, you will see red blood cells adjacent to the biopsy. So you will see a few red blood cells in the interstitium as well as adjacent to the core. I will call something as interstitial hemorrhage when I see a lot of extravasation in the interstitium, okay? And etiology-wise, specifically, when you talk about interstitial hemorrhage, I'm thinking about like infarction, I'm thinking about medullary angiitis. If you are talking about a transplant scenario, I'm thinking about AMR. Those are some of the common scenarios where you see interstitial hemorrhage in context of biopsy. Vasculitis can sometimes do that too. Okay. So on this one, let me show you a case. In this one, right, I said that sometimes the type of inflammatory cells are going to help you out in picking up the etiology. Like in this one, there are a lot of neutrophils. Can you identify that? In most of the cases where I showed you earlier, there was single-lobed nuclei. In this one, there are polylobed. Can you appreciate 1, 2, and 3 lobes over here? So over here, I'm showing you cells which are polylobed. And these are neutrophils. They are present within the interstitium. They are damaging the tubules, causing the tubulitis, and they're present also within the tubules. And at places, the neutrophils are cuffing around the tubules, okay? They are just lining the tubules around. This pattern and this features which I just mentioned, if I show you this one, you will think about pyelonephritis. So interstitial nephritis, but just because of this pattern, when I call you with the result, I will say, hey, I'm thinking about infection on this one. Can you do a urine culture? And this is a very classical for a film, and you all should be able to pick it up. Can you all see the beautiful neutrophils and the morphology?
Yeah, and there's some injury there in the tubules. Yeah.
And a lot of neutrophils. So you can ask me, next question will be, do you think this is ascending or this is bloodborne? Because you can ask me that question, right? And I'll be stuck. So can I help you out and say that, am I looking at infection which is ascending or is it bloodborne? What do you think, man? Can I help you out with that? Most of the time I cannot, right? But sometimes I can. If I see the inflammation predominantly, like this is like a medulla, I see ton of inflammation and mostly those neutrophils. Can you see that? It is predominantly within the medulla. If I see that, most likely it is coming up from the ascending infection, okay? I can make a wise guess and tell you that. Perfect scenario will be if I can show you the track from where the inflammatory cells have come. So in this biopsy, and right here, what is this? Is it a kidney? Which part of kidney am I?
Looks like you've got a lymph node there.
So this is the urothelium, actually.
Okay.
Pelvic urothelium. So I was telling you about etiology. Rarely I can tell you the etiology. This is most like an ascending infection because I showed you inflammatory cells within the medulla, and this is the renal pelvis. I'm seeing.
What do we have a biopsy of the renal pelvis for? What's going on?
Man, you won't believe. This is a deep biopsy.
Very deep.
Where I can see the urothelium and the inflammation. But on this one, I can definitely say, Matt, you are dealing with an ascending infection. Most likely, you are dealing with an obstruction, and you are having infection because you can see inflammation within that, just beneath the urothelium, and you can see the inflammation within your medulla, as well as that inflammation is going inside the rest of the renal parenchyma. So depending on the biopsy and how it helps, I can tell you the etiology also sometimes, okay? So I think now you are an expert, okay? Matt, you don't think? You think, right? So I will show you some. I want you to tell me the etiology.
I feel good until you show me the next slide, and then I'm like, hold on a second. All right, this is an H&E.
This is exactly what I have told so far.
This is a lot of cells. I see some binucleated going on in there. Looks like some neutrophils are having some fun in the interstitium. The tubules don't look that happy at all.
Agreed.
I don't see any eosinophils.
Perfect.
So I think we need to get him vancomycin.
Like infection, right? So you're calling Samira and telling Samira, hey, Samira, I think you are dealing with a phyllo. And Samira asks you, Matt, can you tell me the etiology of this phyllo? Can you help her out?
No.
Anyone in the audience? This is an audience poll question. Can anyone help Samira? Samira, I can help you out. Okay.
So there's so somebody said fungus.
Oh
Yes.
no, there's a fungus among us.
Can you see that?
Oh gosh, no. Please don't do
the
this
low
to
part,
me.
I'll go again on low part. So everything which we discussed earlier is present. A lot of neutrophils, a lot of debris.
Where's the fungus at? I was looking at all the
Can you see
nuclei.
the structures? Right
I see them now.
Yes.
It's so funny. I was looking
They
at
don't
all the
belong
other
here.
small cells. I wasn't looking at those.
Yeah, so they don't belong here, right?
Yeah.
And you can see like a pipe, like hyphal forms, what we call, like a structure, like a tube.
Okay,
like
so maybe my vancomycin comment was not right. I think voriconazole might be a better option.
Yeah. So let me go ahead and show you some other
So
things.
credit to Geetika Singh for getting that correct.
Fantastic job.
She's other kidney pathologist who helped you out though.
They have an opening at Arkana.
Yeah. Can you appreciate this is a PA stain?
Oh, hey, I was going to say that's a PAS stain. Now they have lit up some very abnormal structures.
Yeah, and
those are not tubules.
Yeah, they're all fungal profiles.
Oh gosh, those need to get out of there now.
Yeah, you're seeing a lot of fungus out here.
So cool. So PAS is really becoming a versatile tool for us.
Yes. And
if you're trapped on a desert island, is that the only stain you would bring if you could only bring one?
My personal favorite is PS. If you are going to ask me for a diagnosis and you will say that I will give you only one, it's like that will be the PAS. I won't give you the best diagnosis because again, there are a lot of limitations for PAS too, because Other stains are also important, but yes, if you are going to give me only one stain and if you need a diagnosis, that will be the stain.
Silver stain time.
Yeah, this is the silver stain time. It is very good for fungus.
Oh, yeah.
Can you see that?
So
This is a
interesting.
beautiful. So there are instances where I can help you out and give you the etiology. So as a pathologist, we do try our best to give you the etiology, but I will say most of the time, it's very difficult for us to give you a specific etiology, okay?
And can you tell us, that's fungus in the kidney? Is that very, very common finding?
No, not a common finding. Like if I have to make a story on that, like clinical history,
Yeah.
Most common clinical history which you will get is that is a transplant patient on immunosuppression.
Got it.
So that's why the patient ended up getting fungal infection. Yeah.
Interesting. So yeah, we've learned a lot now. So you pushed us into infection. That's why the differential is important. Think outside the box. Fungus. Look, don't focus in just on the cells like the immune cells. Look at other things that are around it. And so it looks like I got blood here. So H&E.
So now I think you all are expert in interstitial nephritis. So in this case, we will cruise through and we'll see if you can come up with specific etiology or you are again going to give me a generalized diagnosis. Okay.
Okay.
So we are cruising through this case.
My heart rate's going up.
Let me stop right here. So,
Okay. Got a party in the interstitium.
yeah. What type of cells you're seeing?
Well, they don't look like neutrophils.
Good.
And they don't look like eosinophils because they would be a little bit, those look like all red cells. I don't see any nuclei attached to them up in
Perfect.
those little,
Perfect. You're
they
absolutely
look like red cells. So, some of these look like plasma cells. I see a nuclei.
I'm really threatened now, Matt.
What's that? Is that not right?
Now. You are getting it. You are absolutely right.
Oh my gosh. Did I get my board certification in pathology?
That is amazing. You're absolutely right. If you ask me what is the single most prominent population, it is plasma cells.
Sweet.
That is so just for others in the audience. So Matt ended up deciding they are plasma cells because he saw the cells are having ample cytoplasm. The nucleus is eccentric. So in the pathology term, we call that cytoplasm as amphiphilic cytoplasm. And along with the plasma cells, and you can see a lot of reactive plasma cells. Binucleation, you can see in reactive plasma cells. And there are some cells in the background which are almost looking like histiocytes. Why do I call them histiocytes? Because see, over here, I cannot figure out what's going on. But I can see a cell which has a vesicular nuclei. So this is like cytoplasm. So there are macrophages. So sometimes what happens, you will see a lot of macrophages. They have the vesicular nuclei. So besides plasma cells, there are some lymphoid cells, scattered histiocytes, some neutrophils, not a lot of EOs. I don't see any EOs in this field. So basically, I am talking about some kind of, again, interstitial nephritis. And this is the other feature over here. This is a lot of debris, right? Because a lot of karyorectic debris, the nuclei debris is there.
I'm glad you didn't show me that one first.
This one?
Yeah, this was what confused me.
Oh, yeah, so I'm not here to confuse. I'm here
so
to
what is that? So it's debris and looks like cells have been fragmented and nuclei are in places they shouldn't be.
You're
this is
absolutely right.
Not
so
good.
This is a mess kind of a situation, right? And I want you to highlight those cells. You cannot put them into any particular category we have learned so far. They are histiocytes, but they have elongated nuclei like epithelioid cells. So as soon as I said the word epithelioid, you immediately went into like a granulomatous direction, because whenever you talk about granuloma, you talk about more epithelioid cells. So it's a big collection of histiocytes, not formed a granuloma yet, but I do have some histiocytes. I have necrosis, I have cellular debris. So
is that early granuloma?
This is a good, this is an ill-defined, this is trying to form a granuloma over here. Can you see this aggregate over here? It's trying to form a granuloma here. I'll show you.
Kind of a rounder structure. If you kind of
yes.
take a step back a little bit, you can see it.
Yeah, I agree. So this is a step back. Can you see this structure? This is not a well-defined granuloma. I'm not going to ask a nephrology fellow and show this image and ask them a question on granulomatous interstitial nephritis. This won't be the slide.
Yeah.
So that would be a different slide. But on this slide, whatever features we have mentioned, that definitely takes a direction towards an etiology. So can you give me an etiology, or still you want me to sign it out as tubulointerstitial nephritis and you clinicians figure it out, the etiology? Or do you want me to do something and help you out with etiology? Can I do something for you, Matt, on this one?
I'm always wanting you to do things for me. So yes.
So what can I do which will help me to make a diagnosis on this one?
Get out
Because all
those IHC stains.
What do you want, Samira, on the IHC? Because
all of the CDs, whatever you have.
so all the CDs are not going to help you because we want to diminish healthcare costs also, right? So you cannot do everything because
PAS stain?
Yeah, this is a PAS. So all the features which we mentioned, the normal architecture of the biopsy is gone. You don't see the normal architecture. It is destroyed by the cells. And we discussed all kinds of cells in the initial part on the HNE, and there is necrosis. Let me give you a hint. Samira, this is a transplant patient. So this morphology, is it typical of something? And I want you to do only one stain.
My gosh, please don't bring the BK virus into this.
So BK morphology was not typical of what I showed you. This is a typical morphology of adenovirus.
Oh.
That's what I was going to say. I didn't get the chance, but I was going to say that.
Yeah. So this is, yeah. So adeno is very typical, like that morphology, which I just mentioned, is good for adeno. So in a transplant scenario, if I'm dealing with that morphology, I'll go towards adenovirus. So this is adenovirus stain.
I would think there'd be more with all this stuff going on. Why is it just in the small
it is
spot?
variable. So depending on the cut, so yes, in this one it is not a lot, but depending on the case to case, we have some more examples where there are a lot of adenovirus particles, but it is highly variable. Okay, since you brought up the granuloma part, man.
Sorry, just one more thing about adenovirus. Do you ever see red blood cells since it can be associated with hemorrhagic cystitis?
You can see interstitial hemorrhage in an adenovirus because there's a lot of but I'm not, so diagnose, yes, you can see interstitial hemorrhage, but I'm not going to base my diagnosis on that. So adenovirus, if I'm thinking of the plasma cell or the mixed interstitial infiltrate, necrosis part, granulomatous part, destruction of the epithelium part. So all those features I'm going to consider when I consider adenovirus. Red blood cells might be present in the interstitium, but they are not the diagnostic part of that particular disease entity. Does that make sense?
Yep.
So you brought up granulomas. So this is the slide I can show a nephrology fellow and ask a question on granulomatous interstitial nephritis, because this is classical. So if I am showing a slide to a fellow and I'm going to ask a question on granulomatous interstitial nephritis, this is the slide I'm going to show. You were saying that the well-defined round architecture, see, you can appreciate that in the low part itself, the well-defined round architecture, the histiocytes are clustered together kind of. And
much better.
Yeah, and you can see
H&E stain.
Yeah.
And you see like the rim of all those cells that are coming up to the granuloma.
And you can see giant cells. You can see lymphoid infiltrate in the periphery.
Now this is a new slide. This is like you're giving us another example
different
here.
Case, a new slide. In the last slide, we were suspicious about granuloma. There were some granulomatous infiltrate, but that pattern, I don't think it is fair for me to ask that question to a nephrology fellow. And
now, one thing is I'm trying to understand is like you showed me the one that I was looking at, and then we went to the adenovirus. Was that the same case or different?
Same case.
That was same case. So
same case.
In that case, there was sort of these structures that were maybe granulomas, but not definite. And then this one is massively definite. So I'm just trying to figure out like, what made you decide to do the adenovirus stain?
On that one, that pattern of inflammation was very classical. So,
and then that also had that little spot where you had nuclei that were just like kind of everywhere too. That's typical of a viral phenomenon.
So viral inclusions you might not be able to see. Adenovirus, like
remember that section that had looked like the cells are blown up?
Yes.
That is that virus.
Yeah. Yeah.
Got it.
Okay. So I will suspect viral cytopathic effect in that focus, and I will go ahead and do my stains. So on that one, I started with adeno, but if adeno is negative, I will think about like CMV won't do that. Like BK won't have that kind of morphology. BK is more like a rejection pattern. You will see a lot of plasma cells, lymphoid cells. You're not going to see necrosis and that granulomatous infiltration. So coming up from that granuloma theme, I wanted to show you a pure granulomatous interstitial nephritis. So this one is a pure granulomatous interstitial nephritis. And what is the most common etiology for granulomatous interstitial nephritis? And Depending on the audience, you will hear a different response. If the audience is from US, they will give you one response. And if the audience is from India, they're going to give you a different response. And from other parts of the world, I'll be happy to, I would like to know what is the common etiology in your part of the world for granulomatous interstitial nephritis.
So there's some tuberculosis in the chat.
Yeah, that will be
Sarcoidosis.
Yeah. In US, medications are the most common cause. Not that much sarcoidosis or tuberculosis. In US, medications are the most common cause of granulomatous interstitial nephritis. Definitely sarcoidosis after that. Tuberculosis is much lower. I have to have some risk factors to think about it. But tuberculosis is not that common in US. Medications are by far the most common cause of interstitial nephritis. And even for granulomatous interstitial nephritis, medications are common. But I'm going to definitely do fungal stains on a biopsy whenever I see granulomas, just to make sure, but they're not very sensitive. So most of the time you will end up correlating with the clinical features, radiology, and serology, like the PCRs, to come up with an etiology. Most of the time, biopsy is just a pattern. So we saw acute interstitial nephritis, we saw granulomatous interstitial nephritis, and we saw a ton of examples of phyllo.
Someone mentioned Sjogren's in the chat. Is there anything particular you would see in that situation?
Sjogren's is mostly like plasma cell rich in tubular interstitial nephritis. Sjogren's. Okay. So this is another example. And I want, Matt, can you approach this slide for me?
Oh, see, I should have never said I was going to be a pathologist, okay?
No, I'm trying to train you to be a
right,
pathologist.
fine.
This is a simple one.
That's okay. That's how you never start your, okay. All right. So I'm looking at the slide. I'm trying to find my red cells. I see
right
some
there,
up there. So it looks like I've got an H&E. Okay. I'm looking at the interstitium. So it looks like I don't see any gloms, many. There's one. There's a lot of cells everywhere. I need to zoom in on them to see kind of what type they are.
Okay.
Is that lower core the medulla?
Yes, this is the medulla. A lot of medulla. You're absolutely
Yeah,
right.
that whole thing.
A lot of medulla. This is cortex.
Yeah, the medulla also has a lot of cells in it too. So I think we have interstitial nephritis that's going on in some capacity. I don't know quite yet if it's acute or chronic. Because I need to know.
So when you call Samira, you're not going to give her the etiology, right? You're just going to say, hey, Samira, you have got another tubular.
Yeah, just say, I mean, this is like just my first view from looking out. I can't tell the cell types yet because I need to zoom in on it.
Got it. So without zooming in, you just cannot help her out. Do you believe in magic?
Maybe.
Okay. So if I want you to do some magic, I want you to give her a diagnosis just by magic. Can you do that?
Oh yeah, is there crystals in here? Yes, there they are. It's calcium oxalate.
Yes, oh, amazing.
So cool. Oh man. Shree always has. I think we need to invite you for kids' birthday parties.
So now, just in that power, in that field, when I call Samira and I can give her a specific diagnosis, hey, Samira, I think something is going on with the patient's oxalate. Go ahead and do an investigation so she will have a specific diagnosis.
It's not good. It's beautiful, but not good.
Yeah, I know. So sometimes, yes. So sometimes interstitial nephritis, as I said, can give you a specific diagnosis also. So many times we definitely try our best to give you a specific diagnosis.
Can you remind us what stain you might do if they were not calcium oxalate, but maybe calcium phosphate?
Von Casa.
Von Casa. That's for like bone, right?
You can do phosphate also. Calcium phosphate. Do you want to see that stain? Von Casa?
Yeah, let's see a Von Casa. Let's do it. We're getting into the late hour. So I think Von Casa.
Yeah, late hours. Because you asked, I have to show. Let me see if I have it.
He must be extremely organized. One thing I also is going to mention just while you're pulling that out is IgG4, tubulointerstitial disease. We didn't really talk about that. Can you mention something about that after we see the Von Casa?
This is the Von Casa stain.
And so that is looking at calcium phosphate. Okay.
Yeah.
What kind of scenario would you see that?
You can see calcium phosphate deposits like that, and specific etiology. I think there are some pathologists online So malakoplakia will be a specific condition. You will see like Michaelis-Guttman bodies, and they stain with von Casa.
Oh, that's like from step 1, Michaelis-Guttman bodies.
Yeah. So this is a malakoplakia, and you can see like we are going towards the last hour, but you can see a lot of macrophages and like PS stain will be best. Let me show you the PS stain on this one. Can you see the macrophages right here? A lot of fibrosis in the background and a lot of PAS positive cells over here. So,
Zoom in just a little bit on that. There you go. Perfect.
so this is malakoplakia. You're seeing a lot of macrophages here, a ton of fibrosis in the background, okay? And those macrophages are going to have those Michaelis-Guttman bodies, MG bodies, and you can see those bodies very nicely on the von Casa stain.
It's almost like you got a spoon and just sort of stirred it on the slide.
And this is Michaelis-Guttman bodies on a von Casa stain.
Okay.
Whoa.
You're taking it to another level.
So you asked me about IgG4, man. So let me give you a short rundown on IgG4. So basically, IgG4 tubular interstitial nephritis. So give me any example of tubular interstitial nephritis. If there are prominent plasma cells, okay?
Yeah, that's what I think.
IgG4. Okay.
Plasma cells.
Yes,
that's what I know about it.
And depending on the stage, like am I dealing with an early stage or a late stage IgG4? Extent will be different. In the early stages, eosinophils are going to be more prominent. Fibrosis is going to be less prominent, okay? But as I move more, if I see more chronic IgG4, fibrosis will become very dominant. Like in this one, you're seeing a ton and ton of plasma cells, okay? So you can start suspecting IgG4 related tubular interstitial disease. But before even that, on your IF, you will suspect IgG4. So on IF in IgG4 related disease, you will start seeing TBM deposit. And some cases of IgG4 can have membranous component also. So if I see this pattern on IF, I'm already thinking of IgG4. So when I went to my light, I end up seeing a lot of plasma cells. And then when I see my silver and trichrome, I will end up seeing a lot of fibrosis. Can you see that? A lot of fibrosis. This is a fibrosis. I want to take you away from only trichrome. That's why I'm showing you fibrosis on all the stains, because all the stains are important in kidney because each stain gives you unique information. So that is very important to get.
Before you go off this, and I think we need a little bit of a recap on how you see fibrosis with the silver stain.
Okay. Can you see the TBM thickening right here? The tubular basement membranes, they're thickened like on the PAS.
Yeah, those are thickened right there. Yeah, so like a little bit darker.
That is how you know you're dealing with fibrosis, and you see the tubular dropout in the background. In the normal kidney, we expect a lot of tubules. In this one, the normal architecture of the gland or the cortex is gone. See, this is a lot of distortion of the tubules.
I think that's a key thing. Nephrologists are always like so intent on looking at the trichrome stain that they never really, kind of look at the big picture of all the stains and exactly what's happening.
Someone mentioned in the chat storiform fibrosis. Can you comment on that?
Yeah, that pathologists love that. So the fibrosis, the pattern which you see in IgG4 is known as storiform, and this will clinch the diagnosis.
Is that like also described as like a starry sky or something, or
no? Starry sky is described in infection-associated GN, like the C3 staining pattern is starry sky pattern. Storiform fibrosis is fibrosis, like the fibrosis which I was showing you. The pathologist, yeah, they do call that a storiform fibrosis in IgG4. To clinch your diagnosis, you have to do the stain though, plasma cell stain. And this is the IgG4 stain on the biopsy you did, and you ended up proving that there are more than 10 IgG4 positive plasma cells on the biopsy. But this is not diagnostic though. To make a diagnosis of IgG4 related tubular interstitial diseases, this is one criteria. You have to have other criteria also. So your patient should, and one more criteria. So your patient should have more IgG or IgG4 circulate in the blood. When you do imaging, you should see either enlargement of the kidney or some mass-like lesion within the kidney. And you should have involvement of one other organ to call as an IgG4, because you will see that constellation. And sometimes IgG4 prominence in the biopsy, you can see in other diseases also, like pyelonephritis, ANCA, like crescentic GN can have a lot of plasma cells. And if you do IgG4, you will see that. So be cautious when you make a diagnosis of IgG4-related tubular interstitial nephritis. And one last point, we are getting on time. If in the biopsy of IgG4, if I sign it out as severe tubular atrophy and interstitial fibrosis, you are still going to treat your patient because IgG4 is like a focal disease or a mass-like lesion that might not be representative of the entire kidney. Your rest of the kidney might not be involved. It might not be that scarred. Your patient is going to respond very well with steroids. So even if I say severe FTA in a case of IgG4, you still go ahead and treat your patient with steroids.
Thanks, Shree, and that was really great. We're at the top of the hour here. So can you tell us 3 take-home messages from today's session?
Yeah. So acute tubular injury, AIN, interstitial nephritis, it is just a morphological pattern, like other glomerular disease, which we see. When we see that pattern, we have to correlate with other serological features and clinical features to come up with a specific diagnosis in most of the cases. In some of the cases, it is possible to come up with a specific etiology on a biopsy also, like a fungal disease or a viral disease on an IgG4. But those cases are few. In most of the cases, they are just morphological patterns. They don't give us specific diagnosis.
All right. So thank you everyone for joining us today. This session has been recorded and we will put that on our YouTube channel that we shared the link into the chat. And we'll hope to see you all next month. I think we're planning for January 16th for the next session. Shree, do we know the topic for the next session?
Yeah, we are going to focus on intratubular cast in that session, and Z is going to conduct that session.
Okay, great.
Fantastic.
Well, thanks again, everyone.
Thanks,
and
everybody.
enjoy the rest of your weekend.
Thanks a lot. Have a happy holiday season. Bye-bye.
Happy holidays and Happy New Year to everyone.
Yeah, bye-bye.